Here we are again with the transport maximum. So I will show them to you. So the whole idea of these transport maximums is that when carriers for a solute are saturated, in other words, when you reach the maximum, the excess is secreted in the urine. So that's diabetes 101, everybody. We call that spilling sugar into the urine. The problem is when diabetes is uncontrolled and it's at maximum, transport maximum or above, approximately 185 to start, you are damaging those carriers. They are overloaded and they become less efficient. So you lose the carriers effectively, or you lose their ability to carry, or the carriers no longer are functional, and the transport maximum decreases. That's the biggest single problem with uncontrolled diabetes. Is it the longer it's uncontrolled, the greater the array of problems because you you more eat. It kind of lowers the ability to reabsorb the glucose. That's why it's so important. That's the caveat to all of this. It is so terribly important to make sure that you keep. That's why aggressive control early for diabetes. That's what we were doing. So we were doing this, Warren, in endocrine, and we'll probably review the endocrine here because these guys already had it. But it's so terribly important to know. So exceeding that transport maximum, we call it spilling over. And years ago, that was the criteria we looked at. We didn't have the luxury of all these glucometers and things like that. That sort of made our lives a whole lot easier. Moving on. Most of the resorption, nearly everything in the proximal so really most everything occurs in the proximal convoluted tubules. The vast majority of what we're going to pull back in is already pulled back in, along with sodium and water. Okay, the uric acid, when we have, if we are reclaiming too much uric acid, okay, but typically if we're producing too much uric acid, it manifests itself as another endocrine disorder called gout. Okay, that's uricemia. Okay, it's a little bit different. Typically, it's not so much transport maximums and things like that. The problem is there's just too much there, and then that can cause problems because even the urate, which is what the dissolved uric acid becomes, can crystallize if it's in excessive concentration and cause kidney stones. Okay, and the urea, and interesting, the urea, which we want to basically excrete, we effectively are absorbing it so we can excrete it. This is an interesting nuance about kidney function. We pull it in, create a concentration gradient, and then effectively we can excrete it afterwards and pull other stuff along with the party. So a lot of times that's, we do these things. It's not unusual to do these things. So it's almost like it's a variation of secondary transport, except here we're creating a concentration. I mean, it kind of mimics the proton motive force in the sense that we're pushing out protons, and the fact that we're pushing out the protons not only makes more protons on one side than the other, but it makes a higher positive to negative charge. So we're creating almost like a secondary kind of a gradient that occurs there. Is the way I look at it. So the big thing and what really makes this is the descending limb, whether it's, and we're really referring mostly to these long loops of Henle, but any of the loops, water can leave in the descending limb and solutes cannot. In the ascending limbs, because they're thicker, the water cannot leave, but the solutes can, but they need to be actively transported. In the descending part, sodium can move passively. In the in the ascending part, we have to use symporters and antiporters. Okay, so sodium, potassium, and chloride symporters, and sodium and hydrogen ion or proton antiporters. Okay, so I think of the way we're using it. We're pulling out we can pull out the sodium and excrete acidity, which we don't want. We can do the exchange and normalize sodium and potassium. We want to excrete sodium. We want to retain chloride. We want to retain to a certain extent. So some sodium can pass into the cell paracellularly by this route in that particular ascending portion of the limb. It's a very interesting area. So if you think about where we're expending energy, the vast majority of the energy is in the convoluted tubules, mostly proximal, later So somebody messaged me. Later, distal convoluted tubule, which is mostly involved in secretion, but here in that thick segment, and it's all about maintaining. What you're going to see is this countercurrent system, which we're going to get to ever so shortly. So the distal convoluted tubule and the collecting duct is really, it's when they talk about hormonally, you're not going to do a lot of reabsorption unless antidiuretic hormone is causing the collecting ducts to basically create aquaporins to absorb more water. Okay, so that's where reabsorption, or aldosterone, that big player out of the adrenal gland, okay, is targeting that same area, and that is promotes the synthesis of apical sodium and potassium, and obviously it's energy dependent in this, and as a result, we are retaining the sodium, and again, the water is following it. So that's what I mean about it's hormonally controlled reabsorption. Secretion occurs to a fair amount, and so obviously without aldosterone, big trouble. Okay, so the whole idea in this, when you see it, we want to retain the sodium and get rid of potassium. So because otherwise we have potassium excesses. And again, what opposes it, that natriuretic peptide, which comes from an excessive amount of volume that's sensed by the atrium and to a lesser extent parathyroid hormone. And that's really more about calcium than anything else. So those are all useful things to recall. This is, they summarize it. This is a useful chart because you can kind of see what's going in and what's going out. So here you can see it's sometimes it's reabsorbing things, something you don't necessarily want. Okay. And so you can take a look at what's going in and what's going out. So we're pulling things in, some we're going to excrete later. We're getting rid of ammonia. We're getting rid of protons, some drugs, not all. Water here nearly exclusively. Urea being reabsorbed here, okay. Okay, being urea being secreted in here, okay, we want to get rid of that rather. And here you can see sodium and potassium and chloride trying to normalize those levels that are there. And then subsequently the hormone related things, as you can see with by aldosterone, antidiuretic hormone. And then again, some degree of reabsorption occurs here that's also regulated. And so it gives you a nice summary of what's going, where it's supposed to be going, etc. So tubular secretion, reabsorption reverse, almost completely in the proximal convoluted tubule. So there's only a little, if you want to think of the distal convoluted tubule, other than the hormonal controls, is basically like finalizing. Oh, we got to get rid of a little excess acidity or a little of this. So selected substances are moved, and this particularly in the peritubular. We're not so much about the water here. Potassium, protons, ammonium, creatinine, etc. Okay. Substances synthesized in those cells are also secreted like bicarb. And again, bicarb, you're trying to, it's almost like pH regulation if you want to think of it. So that's what tubular secretion is all about. So what's it's important for? This is where we excrete certain, and that's why if someone comes in an emergency room situation, you suspect an overdose or you suspect drug use. I mean, inevitably, they're doing urines. They're always doing urines. So if they're brought in by the authorities or if they're brought in by themselves and they can't tell you what they're on, this is one of the ways that you're going to find out. You're looking for drugs or their breakdown products that are metabolites, undesirable substances, etc. Urea, we want to get rid of a fair amount of it. Uric acid, we want to get rid of a fair amount of it other than what we can tolerate in the bloodstream. Excessive potassium, and again, controlling pH, as I said before, by protons and by carbon. Pretty straightforward. This is the big player here. The whole idea of osmotic concentration to what roughly is our normal, about 300 milliosmoles. That's a useful number to keep and remember. I'm not going to go into the definitions, not chemistry class. I always forget the difference between osmolarity is volume and osmolality is weight. Is that right? Or do I have it bass backwards? No, osmolality is weight, yeah, and osmolarity is volume, right? Chemistry. I was a chemistry major. I'm supposed to know this. It's 50 years ago. Doesn't count. It's more than 50 years ago. Oh boy. That's why Dr. Badger likes me. We can talk chemistry together. So, you know yourself. If you're dehydrated until you're going to have to rehydrate basically before you can urinate on any type of a regular basis. And if you're overly hydrated, it's the opposite's going to occur. And this is the countercurrent mechanism. It's very interesting because fluid is flowing in an opposite direction in two adjacent segments of the same tube with a hairpin turn. It's a unique construction that creates the mechanism. And there are two. You have the countercurrent multiplier. That's about the filtrate in the ascending and descending limbs. Okay. And it has to do with their close proximity to those loops of the vasa recta. That's the exchanger. Because if you're moving out water and then you're moving out solutes to compensate, they're going to lay there. As part of as development goes on, gradually we have to create a certain degree of normalization or it's going to be self-limiting. You can't just have a lot of water in one area in the interstitial fluid and a lot of solutes in the other area. And in order to make sure that the proportions are maintained, we have a second thing called the countercurrent exchanger. That means we're not going to have an overload of sodium or an overload of potassium or overload of chloride in a given area. So the two work in concert, and they have to do with the vasa recta. And interestingly, they're flowing in opposite directions, the way they're designed, as you will see. So these two countercurrent mechanisms work together. And again, starting in gestation, at birth, after birth, maybe to roughly age 2 to 4 is about when this gradient is established and maintained, if you will. And it goes from really right at the junction of the cortex and the medulla, roughly 300 milliosmoles, normal. Okay, same as our plasma, the same as our interstitial fluid, the same as our intracellular fluid, all the way down to 4 times that approximately. And you're going to see roughly 1,200 milliosmoles, and it's different by about a factor. And this is what they comment on in that handout, the exam crackers, and it would be in any preparatory manual that you may choose to use for the MCATs. What you see is a 200 milliosmol difference roughly from one side of the loop to the other. Okay. On the descending limb, it's going to be roughly a 200 difference to the ascending limb. So that countercurrent multiplier creates the gradient, and the fact that we are pulling stuff out of it continually, the exchanger preserves the gradient. Okay, and then we use this gradient as necessary to vary concentration. And that's the hormonal influence. Do we need to pull back in fluid, or do we need to excrete more fluid, etc.? So that's kind of where it looks like when we get into that cortical level. It's roughly 300. At just about the juncture, we start to make the transition, and then all the way down in those areas. And they're going to focus here. Again, this would be considered the juxtamedullary, and it would be the important. You have the cortical nephrons, the vast majority, and there's 15%. So we only are dedicating about 15% of all these nephron units to the task of concentrating urine. It's very interesting how that goes on. And a lot of things, you yourselves know that. Did I have a lot to drink? Did I not have a lot to drink? It depends. As you get older, you start to be careful having too much to drink at night, or you don't get a good night's sleep, or you have an annoying cat like last night. My wife, Thursday night's Bible study group, and they after the study they BS for 3 hours. So she generally comes in about midnight. Okay, between when I put the dog in the crate and let the cats run, those 3 hours, demanding to go outside. Too cold, come back in. Demanding to go outside every 15 minutes. And if it's too cold and you open the door, and 5 minutes later you open the door and he doesn't go, he hisses at you like I didn't fix it. I'm a, like I can control the weather. This is what I have to put up with. So I kind of have to push him out and go, here, you want it out, leave me alone. But it was sufficiently cold last night. I didn't want to go to sleep, and I have my wife come home at 2 in the morning, and I have to leave her note. The cat's outside, let the idiot in. Oh, that's what I put up with. So here it comes. So they're showing you some pictures of what it's like. So effectively, look what kind of goes on. And it could be a little bit more accurate with the flow. It's not really as well depicted. This is proximal convoluted to distal convoluted. And the vasa recta, interestingly, not the way they're draped over it, they're actually, the arterial side is here and the venous side is here. So they actually are flowing in opposite directions. So you have this hairpin turn for urine flow or filtrate flow. And then you have this hairpin turn for blood flow in opposite directions. And it's a unique system you don't see anywhere else. And you begin, and they're showing you these things. So it involves the loop, filtrate flowing in opposite directions, descending and ascending, the different permeabilities, thin, water can pass, thick on the other side, active transport out of the ascending limb. They are not in direct contact, but they're close enough to influence each other's exchanges because of the interstitial fluid. As the water passes, that concentrated nature of the filtrate is going to impact the filtrate that's making the ascending portion of it. That in itself is very unusual. So the ascending limb is impermeable to water. It's thick, but selectively permeable, and typically by active transport. Sodium and chloride are actively resorbed in the thick segment. Some are passively resorbed in the thin segment. Okay, they just may flow in that way. And when you're talking about resorbed, they're pulling them out of the filtrate and putting them back into the interstitial fluid. So the concept of resorption isn't back into the filtrate. It's easy to forget because I sometimes forget. I say resorbed, it's going into the filtrate. The descending limb, water impermeable to solutes. Water passes out into that, and because over time it has been established and has become hyperosmotic, the water is always going to flow in that direction. The minute it gets into those juxtamedullary nephrons and those long loops of Henle, guess what? It's going to flow that way. It just has to. And so when it finally gets down to the bottom with the water continually flowing out, we now have 1,200 milliosmoles. So the more salt the ascending limb transports out, and interestingly enough, if you read that passage, not a passage, but you read the paragraph starting with that and how it develops, it starts with the active, which what initiates this whole system is the active transport of the solutes out. Okay, there's more sodium, the sodium and chloride sort of starts the process. And then secondarily, the water completes the process. And so that's why you continually have, you want to think of it this way, you always have a slightly different number on one side than the other than you will see by about 200 milliosmoles. So the more sodium chloride the ascending limb transports out, the more water diffuses out in the descending limb. So this is, think of this as being first. Even though we're looking at filtrate flow go descending, then ascending, when we're thinking of how it occurred and sort of how the mechanics of the system evolved, it's solute flow, then water flow. The more water that diffuses out the descending limb, the saltier the filtrate becomes. The ascending limb then uses the salty filtrate to further raise the osmolality in the interstitial fluid. So the constant difference forms, again, gestation and early in growth and development, 2 limbs of nephron loop between the ascending limb and the interstitial fluid. And it just multiplied the longer the loop is as it descends toward the central portion of the kidney or the apex of those pyramids. And they give you a pretty good idea, and you can read through this as easily as I can read it to you, of course, and you can see this and what happens, and blah blah blah. And they typically started here with the sodium and chloride going out, etc. So you can sort of look at it this way: the interstitial fluid, osmolality, water that is induced to leave, it changes, and then we sort of try to rebalance it by pulling out the excessive, now creates that excessive amount of sodium and chloride, we pull it out here, etc. And so over time, you can see what goes on there. The blue is pulling out the water, the red is pulling out the salt. And you can see the difference. Look how hypoosmotic. When it gets that distal convoluted tubule, and indeed the urine that you and I excrete is hypotonic. So it's more water and a certain amount of solute that's in there. Okay, if it was excessively concentrated, and sometimes it is highly concentrated, it can create problems and be much more prone to getting kidney stones. If there's excessive calcium or blood or uric acid, bacteria, anything of those can be a nidus, N-I-D-U-S. That means core. For those things. And they cover that a little bit in this PowerPoint as well. So, and you're just showing you, and you can just read all of those things again that are there. Now, if it just stayed there, those numbers would constantly be enlarging. So we wouldn't have 1,200, we'd have some much larger number that was there. So the countercurrent exchanger utilizes the vasa recta, the capillary loop, highly permeable to water and solutes. The vasa recta is also countercurrent, so blood can exchange salt and water with the surrounding interstitial fluid as it moves through the system. It parallels it, it's draped over it. So the blood inside the vasa recta remains isoosmotic with the interstitial fluid, and it's able to resorb water and solutes without undoing that gradient. That's the beauty of it. That's the exchanger. So the multiplier creates it and concentrates the urine. The exchanger retains that all the way roughly 300 to 1,200 that we see in the in the preceding illustrations. So it maintains this without it going away. Prevents rapid removal of salt, removes reabsorbed water. Okay, water in the ascending vasa recta comes from the descending vasa recta or is reabsorbed from the nephron loop and collecting duct. So there's a variety of ways. The volume of blood at the end of the vasa recta is greater than at the beginning. It's just the way it works. So and it has to do with the water. So you have if what they're describing here, okay. So it comes from multiple areas that are there. So it's almost, if you could imagine that the blood itself in those capillaries is regaining fluid as well as regaining as returning to its normal concentration. It was, let's say, think of it being just a tad thicker. Might be the way to describe it, but it doesn't, not so much that it would impede the flow. And they're just showing you the different areas where as the gradient is being preserved. Once it's established, again, 2 to 4 years of old, 2 to 4 years of age on average, now it can form, depending with dilute or concentrated. Without that gradient, we would not be able. So we get 300 milliosmoles to conserve water. Effectively, we would not be able to raise urine concentration. We would not be able to hold water. Okay, overhydration, a large amount of dilute urine, and with the things that reduce it. If we're overly hydrated, we use antidiuretic hormone production decreases, so the urine we can get rid of the extra fluid. Aldosterone, except additional ions, we can remove even more. Dehydration, a small amount. Okay. When we really get the urine is exceedingly concentrated, that's when we're going to be able, then you're going to have a maximum amount of antidiuretic hormones secreted. What do our bodies do in the case of severe dehydration? They hold on to the water. It's the old story. You hear that you can go without food for 3 weeks and water for 3 days and air for like 3 minutes. We know those numbers are not hard, but it gives you an idea. This is what your body goes into emergency mode, holding on to as much water as possible. And it's, I guess, it's sort of the beat because I recall distinctly when my one stepson was a geologist and loves to go into the desert, lives out in California. I mean, we go to Death Valley when it was super hot, one of those things. I mean, we were going to go into basically out of Palm Springs, which is ridiculously hot in the summer anyway, to Joshua Tree. It was like 115 degrees, something ridiculous like that. I mean, we were just took off, but he's like, no, we are going to stop and we're not going in there without water. All of a sudden, we came out with like 10 or 15 gallons of water in gallon jugs and stuck them in the big van I had rented. It was like, hey, we're not going there because you don't know. That'll be in your car because in order to go where you want to go, you're driving like 30 miles into the park. I mean, you're in the middle of nowhere. Crazy. And they're just showing you that. So, what helps to form that? Urea entering the filtrate in the ascending limb. Okay. Cortical ducts resorbing water deep in the medullary rim, now highly concentrated urea. So, urea moving to a certain extent plays a role in that. That might be useful remembering. And treatment wise, there are different things that play a part. For years, we used diuretics. They are not, they were, because the whole idea of treating blood pressure was to diurese, to get rid of the fluid. Problem is, they're hard to tolerate. People with particularly with potassium, were losing potassium, and it led to arrhythmias. There are better ways, like I said, calcium channel blockers, things that impact that renin-angiotensin system. You know about alcohol, it inhibits ADH. That's why when you decide to go out for some drinks, you're going to be running to the bathroom. Okay. Caffeine or drugs for hypertension or edema, those are the kinds of things that, again, will inhibit reabsorption. So, and water not following it, so you're going. Loop diuretics, those are the big ones we use in the hospital. They inhibit that medullary gradient. So the most famous of those is called Lasix. In a passage, you will see that that's the trade name. The generic name is furosemide. These are little words I would start to remember. Furosemide. And osmotic diuretics are used so effectively that's what glucose is. So a lot of times, if someone has ingested a lot of toxins, we will give them like certain substances, like a sugar we don't use, like mannitol. Okay, and it'll act like glucose because it doesn't have as adverse effects as glucose does, and it will pull stuff out in the urine. You're trying to get the toxins out of somebody's system. We may have better ways. That's back in the emergency room, that's what you would do. You would hang different things in an IV and try to pull it out of their system. Give them activated charcoal, induce them to vomit, the whole thing. Put the NG tubes, nasogastric tubes, what you call pumping your stomach. Basically, that's just a nasogastric tube, which is no fun. And the whole idea of urinalysis is a great indicator, not just for illegal substances, but for assessing renal function. It's a quick snapshot. That's why it's such an easy test. So we look at nitrogenous wastes. Okay. So we can do it in the blood with that, and we can determine it in the blood and the urine. Okay. Are the way we were able to determine these types of things. So there's different ways to assess it. The urine is a very quick snapshot to make sure everything's working right. And if we want to find out just to what extent the kidneys are working, we have to evaluate what's called GFR, glomerular filtration rate. So that's how we do it. We give them a substance we know. And so typically we give them a substance that we know is neither going to be absorbed or secreted, something that's just going to pass through. And then you collect urine for 24 hours. You give it to them, and this is a classic means. And so 24-hour urines are used more frequently. They're not fun because you got to collect it, and it's kind of messy, and you're bringing this plastic gallon jug to the doctor, to the clinic. It's a little embarrassing, but that's You learn not to get embarrassed by those types of things. So you want to do this. So you can calculate. I'll skip that. So typically, what they would do. This is a polysaccharide that's freely filtered, neither resorbed or secreted. It'll clear in 125 millimeters per minute. So if it's less than it, or if it's greater than it, it's a problem. Okay. So we want no net reabsorption or secretion. That's there. And so that's how we configure, we look at renal clearance about that. So that's one of the ways we are able to do that. So we utilize a substance similar to that, collect urines over 24 hours. You monitor input and output to determine the appropriate amount, and you measure to see if it all went in, did it all come out. So that's the GFR, glomerular filtration rate. Okay. And if someone has chronic renal disease, and you estimate this just looking at the blood tests, like you're looking at your BUN, your creatinine, your electrolyte levels, and you'll see on a basic metabolic panel. I'm sure I showed you mine sometime. Did I ever do that to you guys? I'll remember to do that. I'll bring my computer and we'll do it in the lab. And we're doing the blood thing. And you always have estimated GFR. And if it's over 60, you're like, happy dance. That way, your family doctor or your intern, whoever's ordering a test, will go, that was a little sketchy. We better get you in and do some more tests to make sure you're not having a problem with your kidneys. Maybe you're not tolerating your medicine, etc. So if it's lower than that for 3 months, now you have diabetes, high blood pressure. They all damage your kidneys over time. Filtrate rate decreases, waste accumulate, etc., etc. Renal failure if it gets below 15. Uremia, which is how it's envisioned. It's interesting. When someone's getting that way, if they have chronic renal insufficiency, it's a very good teaching point. Very itchy. Okay. Urea that accumulates excessively in your body. Very itchy. I don't know why. And you do very abnormal things. This happened to my grandfather because he had a kidney removed long before they knew this. He died in '76. They used to remove kidneys, and he had one removed early on because of a medicine he had taken that had damaged his kidney. And so he only had one, and so he succumbed basically to chronic renal failure at age 86. His heart wasn't strong enough to do dialysis at that time, interestingly enough. And I mean, he would be doing very unusual things, as particularly when he was still at home and then in the hospital and things like that, as I recall it vividly. Okay, because it was the first relative family member that I knew of who died. It was very, very interesting to remember it acutely. So, I mean, it's really weird. The mental changes and the itching, which they don't talk about in here. And I mean, these were the treatments, but if it was at age 86, hard to tolerate things like that. Because hemodialysis puts a big strain on your heart. Your heart has to work extra to push it out to the machine and get it to come back in. And so lastly, what's in there? 95% water, 5% solutes, urea, uric acid, and creatinine. Those are all those waste products that are nitrogenous wastes that are there. Typical solutes defined. You'll always find sodium, potassium, and any normally high concentrations of these, or if we see protein, suggest damage in the kidney or infection. White blood cells, same deal. Bile pigments. Okay, so why are you getting bile in the urine excessively? Now you're looking at liver problems potentially, gallbladder blockages, etc., etc. So all of and you just learn a ton with it. I mean, it just gives you an idea. Proteins. I mean, sure, could be pregnancy or physical exertion, pathological over a certain amount, infection or inflammation of the glomeruli, etc. Hypertension, heart failure, renal disease, ketones, obviously diabetes, a big player. Unless you're on a ketosis type diet, a carbohydrate by intent, you want to be there. Hemoglobin, transfusion reaction, a big player. Burns, a big player. Bile, liver disease, almost exclusively. Maybe gallbladder. Again, This is what you remember when you see hematuria. If it's gross, like I had, particularly as somebody who had a history of smoking or was an active smoker, bladder cancer until proven otherwise. Period. That's gross hematuria or trauma if you were in an accident. Microscopic is more common. Then when you're looking at this, then you wonder what's going on. Is it a stone? Is it an infection? So there's a difference between microscopic and macroscopic. So gross hematuria, other than color, and a lot of medicines change color of urine, and again, urinary tract infection. So these are all the things. Okay, deep yellow pigment from hemoglobin breakdown, also bile pigments, and then anything that's abnormal, you look at. Okay, the odor, it's like the longer it's there. In the old days when we had diapers that you had to wash, you had that ammonia type as opposed to the disposable diaper industry. And then different things, that acetone smell characteristic, pHs, you dipstick the specific gravity, okay, because it gives you a good idea of a quick measure of the water and solutes. And I think that's everything. All right, we are done. We will look at those questions Monday, and we will. So I'll be here, and I'm